Hello, everyone, and welcome to the 8th Annual Shkreli Awards. My name is Vikas Sani, and I'm president of the Lown Institute. The Lown Institute, for those who don't know, is an independent think tank advocating for bold ideas for a just and caring system of health. We envision a healthcare system that's focused on what's best for people, like hospitals caring for those most in need, patients living without fear of financial distress, and health professionals finding joy in their roles. Our signature project is the Lown Hospitals Index for Social Responsibility, which is the first hospital ranking to include measures never before used like racial inclusivity, avoidance of overuse, and pay equity. You can see more about the index and all of our innovative projects on our website, lowninstitute.org. So if this is your first time at the Shkreli Awards, this is our top 10 list of the most egregious examples of profiteering or dysfunction in healthcare, named for the pharma bro, Martin Shkreli. We gather these stories throughout the year, including nominations from Lown Weekly readers. Then we ask an esteemed panel of judges, clinicians, activists, researchers, journalists, and others to vote on their favorites. Showing all these stories together paints a picture of a healthcare system in desperate need of transformation, not just because the stories are shocking, but because often what they're depicting, like Martin Shkreli's infamous price hike, is perfectly legal. We see people like Shkreli profiteer because that's what our system rewards. In 2024, our health system failures were put into the spotlight. The public uproar after the killing of the United Healthcare CEO became one of the year's biggest health news stories. Yet doing the Shkreli Awards for nearly a decade has shown us that dissatisfaction with healthcare is not new. This wave of frustration is the culmination of feelings that have been simmering a long time. We also know from doing these awards, it's not just big insurance companies. There's also big pharma, big health systems, and policymakers captured by industry. As you'll see with the Shkreli winners this year, there's plenty of blame to go around. Now, the good news is we may be at an inflection point. I think everyone agrees that the system is broken and we need change. Our hope is that the stories you're about to hear will illuminate where the change is needed, encourage us to turn these frustrations and take collective action. So before we announce the awards, let's bring on our guest to help with the countdown. Gary Schweitzer is a retired journalist and adjunct associate professor at the University of Minnesota School of Public Health. He specialized in healthcare journalism in his 50-year career in radio, television, multimedia, and web publishing. He published the website Health News Review for 16 years, and that helped readers improve their critical thinking and develop skills to really scrutinize the claims and studies that supported a lot of the medical industrial complex. Patricia Kelmar is Senior Director at U.S. Public Interest Research Group, where she directs healthcare campaign work and provides support for state-based health initiatives. Her prior roles include as a Senior Policy Advisor to New Jersey's Healthcare Quality Institute, and she was Associate State Director at AARP in New Jersey as well. So Gary, I think you just launched a Substack last year. Can you tell us a little more about that project and how it's going?
Well, Vikas, first of all, thanks for having me be a judge again and to comment here today. As you said, I'm retired. When funding expired on our healthnewsreview.org website in 2022, I thought I would hang it up. And then one day, just 2 months ago, my wife sent me a link to an article. I looked at it and I thought, I saw the headline. I thought, I'm not going to look at this. But I wanted to act on her suggestion, and it rose me up off the couch of retirement and led me to start commenting again on the quality or sometimes the lack thereof in in healthcare journalism. So it's been fun. I just want to say right at the outset, since I think I've been known as a healthcare journalism critic, I think these awards today also should be a sign of the vibrant, vital, investigative journalism on healthcare issues that is displayed in each of these examples today. These are not, as so often healthcare news stories are, based on handouts from PR companies or medical centers or drug or device manufacturers. These stories required an investment of time and resources, often deep data dives, interviewing people who didn't want to be interviewed. So as we look at the dysfunction in healthcare with these awards, let's not lose sight of the excellent journalism at play here. And if we want to talk about something that can be done about this mess, this is one thing: support journalism like this.
Gary, thank you. You've stolen some of my thunder from a few minutes from now, but perfect segue. Patricia, what are some of the healthcare campaigns that your public interest research group is working on, and you in particular are working on?
Yeah, thanks. Thanks for having me today. So we work on high value healthcare. So that is the intersection between how much we're paying for our healthcare and what kind of quality and good outcomes are we getting for that. So these awards are right in our wheelhouse of the kinds of issues that we worry about. We've been really involved in addressing surprise out-of-network medical billing. Today we had a great announcement that we're getting medical debt off of credit reports for lenders, so that, because we all know medical billing is not accurate. Many times people are still fighting their medical bills. So we're working on making sure that medical billing is more accurate. Prices are reflective of the costs of healthcare, so addressing situations in our healthcare system right now where we see such great consolidation, anti-competitive practices, and there still continues to be, as we'll talk today, a lot of fraud and abuse in the system in general. All of that driving up healthcare costs for our system as a whole, our public healthcare dollars, and then for the individual patients who are experiencing this as well.
Thank you. That sounds great. Important work. So, but before we get to the awards, I want to draw your attention to something new we're doing this year. We wouldn't be able to have these awards, as Gary so eloquently said, without the smart and courageous journalists who break these stories. So with high quality investigative journalism harder and harder to come by, we think it's more important than ever to honor the work. So this year, the journalists behind these stories will be receiving a Shkreli Reporting Award. And I have one in my hand here. So you'll see the journalists on the screen as we go through the awards, but please give them a round of applause at home. We could not be doing this work without them. All right, so without further ado, let's do the countdown, the 2024 Shkreli Awards. Brace yourselves, here we go. Number 10, Texas Medical School allegedly neglects to notify next of kin before selling body parts of the deceased. An NBC News investigation revealed that the University of North Texas Health Science Center in Fort Worth dissected and distributed unclaimed bodies without properly seeking consent from the families. The center's business supplied the body parts to major for-profit ventures like Medtronic and Johnson & Johnson. The investigation found repeated failures at the center and at the county level to contact family members who were, in fact, relatively easy to identify and reach. For instance, family members of Victor Carl Honey, a veteran entitled to a burial with military honors, were understandably disturbed. It turns out that before he was cremated, Swedish medical device maker paid $341 for Honey's right leg. A Pittsburgh medical education company spent $900 for his torso, and the U.S. Army paid $210 for bones from his skull. Following the NBC investigation, University of North Texas suspended its body donation program, terminated the officials responsible, and initiated both internal and external reviews to try to address these ethical breaches. So, you know, I can't help smiling. It just sounds so macabre. It's more like a Halloween story. Gary, what are your thoughts? What's your
I had noted that I've been a judge for several years. I think this is the most macabre story that I've ever reviewed. And it was actually one of my top 5 worst nominees, which may speak, the other judges put it at number 10, but I think this is a reflection of this year being the worst of the worst. Any of these could have been number 1. The quote that hit me, Vikas, from the sister of that military veteran that you mentioned, she said, "It's like a hole in your soul that can never be filled. We feel violated." And if any of you think about how you have dealt with the death of a loved one and the sacredness, if I could say that, of that moment and those moments, and what you felt, and you think about her pain, you'll understand the depth of this story. More than that, or in parallel with that, these practices could potentially jeopardize the reputation of the future of medical education, which relies on donations of bodies for medical student dissection and study. I also want to note this isn't the only such example that even NBC News alone has reported on. NBC last year reported on coroners and medical examiners in several locations repeatedly failing to notify families of loved ones' deaths before burying them in paupers' graveyards. So a really
Thanks,
sad
Gary.
one to begin with.
Do you want to add anything, Patricia?
Nothing to add. I mean, clearly, my heart just goes out to those families that discovered this. And as Gary pointed out, right, this could indicate a deeper look into how should this important research be done, and is there not enough supply that we're resorting to this kind of thing? So we do want to have this kind of research available to the educators, but at this expense, no.
Yeah. Well, you know, I'll just add one item. As I was looking at this, what struck me was that the leadership at University of North Texas, you know, fired the officials, and they've implemented inquiries, you know, which is all, I think, proper. But to me, it illustrates something we see a lot in healthcare. We've seen it at Lown in some of our work around medical debt and financial assistance, and you know, in the medical debt space, the news articles and the reactions to them are illustrative, which is quite often senior management sets a tone, sets a direction, but doesn't know the details of what's going on. But in many ways, what's going on like this is that people are on autopilot around certain ideas or principles. And I think one of the lessons that we should take away, and one of the things we have to address, is if the fundamental guiding principle, the North Star, is the bottom line, you're going to get things like this. And so that's a responsibility of leadership to sort that out. Anyway, we better keep going. We don't want to get behind right at the first one. Number 9, out of the mouths of babes, a taste for tongue-tie cutting intensifies. Despite a lack of evidence showing effectiveness, baby tongue-tie cutting procedures are being touted as a cure for everything from breastfeeding difficulties to sleep apnea, scoliosis, and even constipation, according to a report by the New York Times. Typically recommended by lactation consultants and then performed by dentists, the procedure involves cutting away the tissue that connects the tongue to the floor of the mouth. So this is like an emerging lactation dentistry medical industrial complex. I don't understand what's going on. Serious complications are rare, but according to the report, some babies experience enough pain that they refuse to eat, become malnourished, and even require hospitalization. As interest in the procedure grows, equipment makers like BioLays were keeping pace. At an April 2024 event for pediatric dentists billed as tequila and tongue ties, representatives for the laser device company trained attendees on the procedure before doing rounds of tequila shots and margaritas. So I'm gonna take this. Lord, I mean, I don't know where to start. I should add that, they had a third annual frenectomy fiesta, which was advertised as Nacho Average Dental Meeting. So I think this belongs like with the movie The Big Short, when they went off to the securities conference and they were whooping it up. I mean, it kind of illustrates the background culture for those people who are not aware of what goes on behind the scenes in medicine. This is like a classic of a sort of vague theory with little evidence, but a great outcome in terms of finances, taking off like wildfire. We see this routinely last 10, 20, maybe 100 years in medicine. So it's not particularly new. The other thing I'll point out is that BioLays declared bankruptcy just a few months ago. So who says markets don't have a moral compass? Anyway, either of you want to comment on this one?
Well, this was also one of my top 5 worst nominees. And so you can add this to the wall of shame of practices that you can't believe are still flourishing. The story cited a German obstetrician warning about this procedure 234 years ago, warning of, with his words, abuse from profit, greed, and ignorance. How slow we are to learn.
Vikas, I'd also just jump in here and say, this isn't just happening at these medical conferences, right? We have drug specialists going in, medical device specialists going into doctors' offices every day, right? This is a common practice to have a branded company representative walking in and educating, the providers and maybe dropping off a nice lunch along the way. So it's still happening. I think, there have been attempts to get at this, what we often would call drug detailing when it was a pharmaceutical rep. To have an ability of non-branded specialists for different entities and different specialties to come in and talk about the variety of medications or the variety of devices or surgical options, and have it be more of an education as opposed to a marketing person coming into a doctor's office.
Yeah. Well, education and marketing are sometimes very fuzzy lines, especially when it comes oftentimes to devices and new procedures where, the regulatory mechanisms are very different. That brings us to number 8, patients shocked by device makers' billing practices. Zynex Medical, a company specializing in nerve stimulation devices used for pain management, faces scrutiny over its billing practices. According to a report in Stat News, patients were receiving Zynex devices, understanding the expense would be covered by insurance. But very soon after, unsolicited supplies of items like batteries and electrode pads began arriving in waves, often in quantities that far exceeded what was necessary and at an inflated cost. In the end, either the insurance company pays or patients get stuck with a surprise bill. Stat reported that almost 70% of Zynex's 184 million in revenue in 2023 came from batteries and electrode pads. That's just a classic razor blade model of a business. The company didn't respond to Stat's request for comments, but maybe we can have some comments now. And by the way, that picture you saw was of a pile of device batteries from an eBay listing. So clearly people are overloaded with this stuff and trying to get rid of it. Patricia?
Yes, this is just classic overbilling. It's fraud. It puts both our public health dollars at risk and makes us needlessly spend for extra supplies that aren't needed. patients are, as we saw in this story, right, put on the hook for paying the full bill when they thought that it was going to be covered, but then insurance catches on to the scam and says, I'm not. Now the patient has, a stack of supplies, and they feel oftentimes like they owe the money, right? Because they have the material and that's what they're being told. So it's just a terrible abuse. I would just say, in the pain, when it comes to pain, this is an area where we see a lot of fraud and tricks and scams. People are desperate to be relieved of their pain. So we see a lot of profiteering in the pain treatment space, and folks have to be really diligent to make sure that they are not a victim to it. I think, it would be great if there was a way, the story points out that, physicians would catch on to the practice, but that was just one physician after another. And we need to have a better way of, like an alert system that this is the kind of practice that certain industries have, and get that out to the specialists that might be using those and prescribing those treatments.
Yep.
I've gotten calls from people who are like, they are calling me for the same thing, spending hours on the phone. How do I get them to stop sending it? I don't need it. It's filling up my house. It's a waste, right? And there's no way to solve it because it's not in the interest of the company to stop
Yeah.
sending and billing.
I mean, it's like a machine that's running without a stop button. It's really awful. So let's keep going. Number 7, an emergency flight ends with $100,000 surprise bill for an infant's family. When Sarah England's infant son, Amari, experienced severe respiratory distress 2 months after open heart surgery, doctors at Natividad Medical Center in Salinas, California, determined he required immediate specialized care. So Amari was put on a ventilator, and doctors arranged for an air ambulance transfer to the medical center in San Francisco. The boy eventually recovered, thankfully, and returned home, but that's when England got another shock. According to KFF Health News, her insurer, Cigna, had refused to cover the 86-mile flight, leaving the family stuck with a bill for $97,599. The No Surprises Act is supposed to protect patients from exorbitant out-of-network charges that come from situations like this. However, if an insurer deems the service as, quote, not medically necessary, unquote, as Cigna did in this case, patients can still be on the hook for the bill. Patricia? Oh, what happened?
Sorry about that. I don't know what happened.
Oh.
So I've worked a lot on surprise billing, and when I first saw this headline, I thought, "Oh my gosh, somebody's violating, the No Surprises Act." But you were right, right? Like this is a claim denial, and this is happening everywhere. A lot in emergency treatment, but in all kinds of treatment, where the patient is doing the best they can. Imagine this situation. Here's this mom with a child who has a history of illness. They go to the emergency room, there's trouble breathing, they're being told the best thing to do is to send your baby to the best specialist, and it's so important, we need to send them by air. So the medical denial was an argument of whether it should have been ground ambulance transportation or air ambulance transportation. Now, how is the patient supposed to know what is more appropriate? They are relying on the experts. And so this is a situation that too many people are facing where they're following medical advice. They have limited information as to what is necessary, what is an emergency. And then at the end of the day, though, they are left paying that bill and they don't have any recourse. They can try to appeal, but this is an argument between the people who ordered the test or ordered the treatment or in this case, ordered the transportation, and the insurance company that is saying it was not medically necessary. In this case, the article even pointed out that the patient was not able to get any support from the hospital that ordered that air ambulance to take the baby, right? So So there is the patient, the mom, trying to write a compelling appeal letter to make sure that the insurance covers it, trying to make an argument that an ER doc or whoever ordered it would have, and so she was really stuck in a terrible bind. And this is a great case where, like, even though we see a lot of stories about medical billing and ambulance and emergency billing, we need reporters like Molly Work who come out and write that additional story, shed more light on the situations that need solutions.
Yeah.
And we need to hold our providers accountable for the treatments that and services like emergency transport that they're responsible for,
Yeah.
that they've started down the pike.
Thanks, Patricia. I can, first of all, let me just acknowledge that the reporter for this story is in our audience today, Molly Castle Works. So let's just give her a nice shout out. I want to say I've been there as a practitioner. I practiced on Cape Cod. Sometimes we had to face the question of how to transport, and on the Cape, it was sometimes a toss up between ambulance on the ground and air ambulance. Sometimes the fog mattered. But one thing I can say for sure is that decision was never, something that we asked the family, which would you prefer? I mean, this is absurd. And it's exemplary of how the healthcare system works. It's a lot of dysfunction. Patients and families are left holding the bag. It's terrible.
Just a quickie, Vikas.
Yeah, really quickly, Gary, because
Yep. So KFF Health News and NPR, who reported this, have this really interesting recurring feature called the Bill of the Month, which is worth following. It's crowdsourced. You can submit your interesting medical bill to them. This nominee was from that series.
Yep, thanks. All right, number 6. Here's a story that's going to piss people off, perhaps. In 2023, a massive surge in Medicare billing for urinary catheters left patients shaking their heads. Up to 450,000 beneficiaries had bills for catheters submitted on their behalf, representing an 800% increase over previous years. Just 7 suppliers were responsible for $2 billion of these suspicious charges. That's nice work if you can get it. When the New York Times looked into these suppliers, the curiously named Pretty in Pink Boutique, they found no medical business at its address, and its phone number rang a random auto body shop. One woman had 2,000 urinary catheters billed in her name that maybe thankfully she didn't receive, or else we'd have eBay flooded with urinary catheters. Gary.
Pretty in Pink Boutique could have been, maybe should be renamed Pretty Bad Stink Boutique. I would give kudos to the National Association of Accountable Care Organizations, which is the advocacy group that uncovered this fraud. But it's also another case of, if you see something, say something, because the New York Times story highlights several individuals who saw something wrong and reported it.
Yep, I think that's an excellent point. In the same vein, my 90-year-old mom switched providers, or, more typically, the other provider left. And after that, she started getting waves and waves of diabetic test strips that she didn't need, and testing equipment she didn't need. It was just ridiculous. Well, let's take a break. So we've been discussing all the massive flaws of healthcare that we need to change for sure. And to get this change, we're going to need strong leaders who go beyond the clinic to tackle our greatest health problems. The Lown Institute created the Bernard Lown Award for Social Responsibility in 2021 to honor all the clinicians who use their voice as a medical professional to speak out for social justice. If you know of a clinician under 45 working in the U.S. who stands out for bold leadership in healthcare reform, environmental justice, equity, or any other humanitarian efforts, you can nominate them for the Bernard Lown Award, which comes with a $25,000 prize. The picture here is from our most recent Blazer Award winner, Dr. Lilia Cervantes, at the 2024 ceremony. So nominations close at the end of January. That's this month. So submit yours today. All right. Let's get back to the Shkrelis. Number 5, no cash, no credit, no chemo. Private equity hospitals' passion for profits sends cancer patients packing. Memorial Medical Center in Las Cruces, New Mexico faces allegations of refusing cancer treatments to patients or demanding upfront payments, even from those with insurance. That's according to NBC News. Previously a nonprofit, the hospital is now operating as a for-profit facility by LifePoint Health, owned by private equity firm Apollo Global Management. Memorial's financial assistance policy, which once included cancer treatment, was altered in 2023 to exclude that because, of course, only rich people get cancer. The hospital denies turning away patients, but multiple reports, patient testimony, and internal documents suggest otherwise. Some local cancer patients have had to travel hundreds of miles to get the care they needed. Gary, first off to you, and then Patricia.
Yeah, so this is another NBC News story, and it's 2 for them. I think we had 2 New York Times already. Stay tuned, we may have some other double winners. But imagine that you worked as a nurse. This is a story from an actual anecdote from the story. You worked as a nurse for a nonprofit community hospital, then left for another job. You were later diagnosed with cancer, but told that your old hospital where you were going, now a for-profit, wouldn't accept your insurance. So you and your husband are one of these who pack up and move 220 miles away to get treatment at a hospital that will accept your insurance. NBC provided the first hospital with the names of 9 patients who spoke on the record about being turned away or having to pay upfront for care. 3 others with similar stories asked not to be identified, and another is deceased. There's another Lown angle to this because NBC reported that even as this hospital charges patients well over its costs, it ranks low in community benefits according to the Lown Institute Hospitals Index, which is a measure of a hospital's contributions to the population that it serves. It got a rating of 1 star out of 5 in financial assistance programs for the indigent or underinsured, and ranked 28 out of 32 hospitals in New Mexico for benefits to the community, according to Lown.
Yep. Private equity is the owner. Patricia, what do you think?
Yeah, we're seeing a lot more of this pay up front requirement from hospitals. And when it's in a highly consolidated situation, you may go miles, and in this case, hundreds of miles before you can escape that kind of upfront payment demand. And so, people are often offered a medical credit card. It's an issue that we're working on right now. We're seeing more and more providers and hospitals asking people to sign up for these so-called medical credit cards, which are really a bad deal, very high interest rates, very high late payments, and also really set people up for, high bills, right? Can you imagine? We can't even get the price of the care that we need to receive in advance, and we're going to hand over either a load of cash or sign up for a medical credit card that the hospital can then charge without knowing what it is. It's a trend that's moving. We need to figure out how to help folks who can't come up with $3,000 or $10,000 up front before their insurance pays to be able to get the treatment that they want. The result of all this upfront billing is that people put off care, right? If you're being told you have to put down $5,000 before you can get your hip replaced, you're putting off care, or in this case, in oncology treatment, having the expenses of moving and trying to find that treatment. So we need a better solution for that, and we need to acknowledge that people just can't come up with thousands of dollars, tens of thousands of dollars for treatment before they even get it.
Yep. And, I'm going to add one other piece. Like if we zoom out, I mean, there's some, I think, really deep questions and fundamental questions that we as a society really have to confront. I mean, maybe I sound like a broken record here, but, the logic of business, the logic of moving things around on the chessboard to maximize the bottom line, which is what private equity has to do because they have shareholders or if it's their own money, they're just trying to maximize what they can get. And there's no upper limit, there's no control. They assume they're going to lose money on some ventures, so they have to maximize what they gain on everything else, similar to venture capital. And so whatever they do is going to be geared towards that bottom line. And the fundamental question is healthcare that kind of commodity? And I would maintain it simply is not. And the fact that we allow this to go on this way, I think illustrates a fundamental category error, and it's going to cause endless harm, endless pain and suffering. And sadly, the people at the very top who are just moving the pieces around on a chessboard are insulated from that. So I'll stop my sermon. All right, number 4. Oncologist leaves unconscionable trail of alleged misdeeds, some of them deadly. As an oncologist at St. Peter's Hospital in Helena, Montana, Dr. Thomas Weiner was celebrated for his exceptional patient care and became the hospital's highest earning physician. However, according to reporting by ProPublica, a troubling pattern of patient harm and suspicious deaths eventually came to the surface. In one case, according to the report, Weiner subjected a patient to unnecessary cancer treatments for over a decade. In other cases, the reporting shows evidence that Weiner provided disturbingly high doses of barbiturates to facilitate death in seriously ill patients, even when those patients may not have actually been close to death. Evidence is also presented in the article that he altered end-of-life plans without consulting the patients, or prescribed high doses of opioids to patients that didn't need them, and he often failed to document his work properly. Weiner was fired from St. Peter's in 2020, and his suit claiming wrongful termination and defamation was denied, but is now under appeal at Montana State Supreme Court. A federal suit was filed against Weiner in 2024, but that was related to his billing practices. Weiner has consistently denied any wrongdoing, and his attorneys have filed a motion to dismiss the case. Patricia.
Yes, this is, heartbreaking because this is one example of a physician who had a long history, apparently, of providing substandard care. This isn't a situation of a mistake, fixing and changing patients' end-of-life plans, overprescribing opioids. This is just straight up bad care, and it's happening across the country, not everywhere, but usually there is a line of patients who've been exposed to this kind of abuse, and we need to make our medical boards more proactive. We need to help patients who are coming forward with concerns about care. Oftentimes, the hospital will quietly settle with them, but then make them sign a non-disclosure statement so we don't have the series of patients coming forward so the medical board can say, well, this is the only complaint we've had, right? So we need to improve the way that we allow patients to have a voice and to explain and to show the concerns that they have about the treatment. In this case, there were patients who didn't even know they were being mistreated, right? And that's when we need to rely on that medical profession itself. And Vikas, I think you talked about kind of the corporate culture in a hospital, right? We have hospitals which have a really great corporate culture where everyone is empowered to point out, no hand washing or call out a doctor for not doing a timeout before surgery and things like that, and giving everyone power. But this was a situation, right, where we've got a doctor who's bringing in a lot of money in the hospital, had a great reputation, maybe just a great financial reputation, apparently. But it was very hard, as the article pointed out, for colleagues, medical professional colleagues, to feel like they could call out bad care, raise the alarm, because they were frightened for their own reputation and what would happen to their career. So it's tragic story. Thank you to the reporters who put the time and effort to track this down. Thanks to for the courage of the patients who came forward and talked about it. That's what it takes, a lot of courage and a lot of transparency to ferret out these doctors. And thank God, eventually the hospital fired them, got them away from treating, but that doesn't always happen.
Yeah, I have a lot to say, but Gary, how about you?
Just real quick, we shouldn't lose sight of the fact that it was a whistleblower physician who first shined the light on this. And if I could, just a plug for a terrific, relatively new book by a friend of mine at the University of Minnesota, Dr. Carl Elliott, who wrote The Occasional Human Sacrifice, Medical Experimentation, and the Price of Saying No, with story after story about the price that is paid by whistleblowers like the physician in this case. This one ended well, if we could say that. Oftentimes they're not.
Yeah.
In that way.
Well, I don't have the time to say everything I would say about this, because this is really, for me as a physician, this is very much a kind of call to arms. I think the medical profession really needs to look carefully in the mirror. I take a slightly different view from you, Patricia, in the sense that while this shows something positive, I think our system is fundamentally broken when it comes, we've had a system 100 years after Flexner with our medical societies and everything else and medical boards that's based on professional autonomy and an honor code and a range of other things. And I just think for the 21st century and the conditions and situations we face today, it's obsolete. It needs to be rebuilt. It needs to be reformed, but in a major way. And there's a lot to say, and we don't have time, so I'll stop there. But it is the case that, physician heal thyself needs, I think, new institutional legs, and we need to figure that out. All right, number 3. A drug company pursues high dose of profits despite risk to patients. That's shocking. Amgen's lung cancer drug Lumakras, how do they make these names? Lumakras, there's Ludicrous, Lumakras, was granted accelerated FDA approval in 2021 at a daily dose of 960 milligrams. The FDA required Amgen to test their drug at a lower dose because previous studies had shown that this could provide similar effectiveness with fewer side effects. That trial, the follow-up trial, showed no significant difference in efficacy between the two doses. Sure, if you look at the table, the point estimate is about a month better, but it wasn't even significant. The confidence bars were so wide, it could have just been random noise. That should be good news for patients looking to reduce the diarrhea, nausea, vomiting, and mouth sores that can occur. But despite these findings, Amgen continues to market it at the higher dose and is moving forward with the FDA process to get final approval at the high dose level. That's according to KFF Health News. There's no sign that Amgen, who stands to lose $180,000 a year per patient at the lower dose, has any interest in changing course. A spokesperson for the company told the Lown Institute ahead of this publication that the FDA has accepted the 960 milligrams as the recommended dose. And I guess that's their defense. Well, I don't know where to start. This is one of these cases, related to the FDA. We looked at all sorts of evidence and methodologies when we were looking at the case of Aduhelm, the Alzheimer's drug, and the FDA process for that. I hadn't had the time, and honestly, I don't have the time to dig in deep to look at all the literature, to look at these trials and their methods. But the little bit I did look at, raised, to me, serious questions. But fundamentally, I think this really illustrates how this whole process works, which is to say, there's a certain set of trials, there's a regulatory authority, the pricing may or may not be part of the regulatory approval. The issue of side effects is sort of on the side, and there's no way of holistically looking at, cost effectiveness, if you will. Like, how much does this cost? What are the side effects? What are the trade-offs? And what's the strength of the evidence? And anybody who knows the strength of evidence is not a black or white thing. It's always a gray sliding scale. Okay, but if that's true, then we need different mechanisms and methods than just saying, hey, you're approved. You can charge $1,000 and we'll figure it out later. My 2 cents. What do you think, Patricia?
Well, just as private equity firms have to get a good return on investment, pharma companies have that incentive as well. So I don't know all the ins and outs of this drug, but what we do know is there's a lot of effort to try to keep a drug on the market as it is. I don't know if this one was protected under patents that allowed them to keep out competitors and keep their prices high. But these are the kinds of challenges that we're facing. The healthcare industry is a business, and businesses drive towards the highest profit they can get. And so we also know that we don't price our healthcare to the actual costs. So there's always that disconnect between what are we paying and what is the profit margin that the entity thinks they need. And I would just also just throw in there clinical trials. There's been a lot of critique about whether or not clinical trials ever make it to the end in some of these prior approved drugs. And so we always have to be tracking the quality of the clinical trial and look long term as to how is this drug working in the marketplace.
Yeah. We got to move on, but Gary, I want to give you 30 seconds. I know you've spent a lifetime looking at how this stuff is reported and the impact it has on patients and families. Any thoughts?
Well, just a quickie. As a journalist, I always look for the money quote. And for me, in this one, it was one pharmacologist saying that this drug is, quote, a poster child for incredibly bad drug development. So a good one for our followers online now and later to look at and learn from.
Thank you. Yeah, I think I probably plan to do that myself. So, all right. Well, you probably knew this next one would be coming. Number 2, corporate healthcare behemoth exercises crushing power. So what started out as a small Minnesota health insurer is now the 4th largest business in the nation by revenue, controlling nearly 90,000 physicians and acquiring influence across the breadth and depth of the healthcare industry in the United States. According to Stat News, United Health exploits its vast physician network to maximize profits, often at the expense of patients and clinicians. Doctors interviewed by Stat report pressure to reduce time with patients and to practice aggressive medical coding tactics that make patients seem as sick as possible. And I should add, just last week, I think Wall Street Journal had a similar piece confirming a lot of these insights. As the largest provider of Medicare Advantage plans, United Health earns higher reimbursements when their patients appear to have more health challenges. According to Stat, this tactic may have allowed the company to take tens of billions of dollars in additional payments from us, the taxpayers, over the past decade. United Health faces a federal lawsuit for this behavior, as well as an ongoing antitrust investigation. And of course, the company denies any wrongdoing. Patricia.
Yeah, well, kudos to the Stat News team and the group of reporters that put the work in. This was a lot of data, a lot of crunching, a lot of digging around trying to find the evidence to support all of the work that they did. I would just say that this is kind of like the story of the issues that I work on primarily as an advocate in consumer high value healthcare. And first of all, it's our payment system Under Medicare Advantage, you're allowed to charge more for the treatments that you're giving. You charge the government more and get paid more if the patient is more sick. So there's an incentive right there to say that most patients that you're seeing are sick, and they get a higher payment rate for that. And is there anybody overseeing that? Is there enough people at CMS looking at patient records to know that the indicator of a highly sick patient is true? No. So we're just setting ourselves up for abuse of that system and, allowing overbilling in those cases. Then we have consolidation, right? United Healthcare, we used to have hospitals buying hospitals buying hospitals. Now we have hospitals buying physician practices, buying, imaging centers, buying pain clinics, buying outpatient surgery centers. So now the self-referrals are going through, right? Your own doctors are referring back to the hospital system, which are referring to this specialist, and they're all making more money because of the higher coded individual patient. So it's a way to drive up billing. It's a way to waste our federal dollars. And it's also drives up patient payments, right, when they're paying a percentage and paying part of their copay or co-insurance. So this is just, a deep dive into one insurance company and how consolidation and payment systems work to drive up the costs of our healthcare.
Thanks. I just want to acknowledge we have some of the reporters for this story. The reporters were Bob Herman, Lizzie Lawrence, and Tara Bannow. I know Tara's in the audience. So congratulations, great work, important work, really in the national interest. So thank you. All right. And number one, our hometown boy, Wreck-It Ralph, CEO follows private equity playbook to bankrupt community hospitals while pocketing plenty. Dr. Ralph De La Torre, as CEO of Steward Healthcare, allegedly orchestrated a dramatic healthcare debacle by prioritizing private equity profits over patient care, according to the Boston Globe. Fueled by debt and sale-leaseback schemes, Steward's expansion and subsequent fall into bankruptcy left hospitals gutted, employees laid off, and communities underserved. I just want to say I heard about nurses bringing their lawnmowers in to one hospital to be sure that it looked fit on the outside because they didn't have cash. De La Torre seems to have made out just fine, however, reportedly walking away with more than $250 million over the last 4 years as these hospitals tanked. Asked to testify before a Senate committee about the hospital system's failure, Dr. De La Torre refused and was held in contempt of Congress. He resigned from Steward, which is now the subject of a criminal investigation. Gary.
Perhaps Dr. De La Torre, when he would not show up to testify, was on one of his 2 yachts that he also walked away with over the last 4 years as the hospitals were failing. Just to show some of the depth of the Globe's work here, they identified at least 15 instances in which this healthcare system's patients died after failing to receive professionally accepted standards of care, including both staffing and supply issues. The Globe reported that Steward Healthcare's hospitals were among the nation's worst. And it's yet another in what we've looked at today, another in the series of amazing tales of prioritizing private equity profit over patient care.
Yep. I want to just add, this is our backyard. I'm in various networks, professional and social networks. What was going on at Steward was kind of on the grapevine for many years. So I asked the question, if we knew about it, where were the regulators? Where was the AG? Where were all the people who should have known better? And if the answer is, well, the law is X and our hands are tied, there's a very clear action item there, isn't there? Let's fix that. So in any case, there's a lot to say about what went on, the details, particularly the various financial juggling. I haven't, written a PhD on this one, but the playbook basically was the standard playbook of LBOs of the 1980s. Is, go watch the movie Wall Street, Blue Horseshoe loves whatever the hell the name of that airline was. And it's basically loaded up with debt. And with all that debt, the cash from that debt, pay yourself a massive dividend and let the operating entity struggle along trying to make the note. Patricia, any last thoughts before we close it up?
Well, it's the nightmare of nightmares, right? And a whole community is being affected by it. And so this is, the shot across the bow maybe for the attorney generals in throughout the states to really take seriously the investment of private equity. There have been efforts in some state legislatures to give the AGs more power to look at the consolidation and look at private equity investment in healthcare. And I think we need to step forward. And if they don't have the power to do what they need to do to put an end to this kind of abuse, we better get it on the books so they do.
Yeah. All right. Well, there's so much more to say about that story and practically all the others. There are also a lot of honorable mentions we didn't get a chance to talk about. So there's plenty more graft corruption and grifting out there if you want to look. So you can go to our website. But anyway, that's it for our awards for this year. You can read more about all the Shkreli winners and see the fantastic reporting that's uncovered these stories at lowninstitute.org. So a big thank you to all of our judges who voted this year. You can see them listed at the webpage. And also thanks to our guest hosts, Gary Schweitzer and Patricia Kelmar. Check out Gary's Substack, which is garyschweitzer.substack.com, and learn more about the U.S. Public Interest Research Group's campaigns at pirg.org. Subscribe to our newsletters to see more recent events. In the coming spring, we're going to be talking about fair share around the country, what hospitals enjoy in tax breaks and what they give back. We're going to be talking about medical debt. We're going to be hosting a conference. There's a lot going on, so we'll see you next time.